Now coming to today's class, we'll be studying about miscellaneous bacteria and we'll be studying about viruses also. So in the miscellaneous bacteria, there are other bacilli species, culturally called as anthracoid bacilli. Except Bacillus cereus, all of them are non-pathogenic. They are actually motile bacillus, produce hemolytic colonies on blood agar. In out of the other bacillus species, one is Bacillus cereus. Bacillus cereus is motile. It is non-capsulated. It causes food poisoning in two forms. Emetic type that is associated with fried rice, milk and pasta, and diarrheal type associated with meat and sauces. Emetic type means there will be a lot of vomiting for the patient, and diarrheal type there will be a lot of loose stools. It is caused, the Bacillus cereus is the disease caused by the preformed toxin which causes the food intoxication. Then next is actinomyces infection. Actinomyces infection, they are soil saprophytes and commensals of the oral cavity. In humans, it causes actinomycosis. Actinomycosis israeli is the most common species infecting man. You have heard about actinomyces, right? There is they are special in the first there is a granule, so that's why it's called actinomyces. The pathogenesis is a chronic suppurative and granulomatous infection. It is characterized by multiple abscesses with formation of sinuses. So there will be multiple abscesses which will have tracts. So tracts, that's why there are formation of sinuses. Discharge contains sulfur granules. That is a specialty of the actinomyces infection. The discharge will have sulfur granules. Actinomyces means raised fungus. So the fungus in microscopy, when you see this, the specimen under microscopy, you will find ray-like projections which are of this fungus. So ray-like appearance of the organism in the granules. The mode of infection includes commensals of the oral cavity, mostly endogenous and result from trauma like dental extraction. Infection may spread to the neighboring organs, including the bones, and induce tissue destruction. So, if once you are this commensals of the oral cavity enters the tooth, the gum area, like after tooth extraction, it then invades the bones and it then causes tissue destruction in the bone. And there will be abscess type swelling around the jaw, and there will be small multiple sinuses, and these sinuses will be secreting the pus, and this pus will contain sulfur granules. So the classical triad of actinomycosis is a chronic lesion with a mass will be there, sinus tract which shows sulfur granules, relapsing in nature after a short course of therapy. So like this, there are many people who take antibiotics. They might take antibiotics for a short period of time. They'll see that lesion is gone, but again there will be relapse of the disease after a short course of therapy. The fibrotic walls of the mass lesion is characteristically woody in nature. So this mass lesion, when you palpate and see, it will be have a classic woody texture. So once it is woody texture, you will mistake it as like a parotid tumor, or you might find a jot. You might mistake it as a jot tumor, but it might be just a actinomyces mycosis infection. So what are the clinical manifestations? Oral cervical actinomycosis is the most common form. It is painless, slow-growing hard mass with cutaneous fistula. That is lumpy jaw. It's called as lumpy jaw. So you have heard about lumpy jaw, right?
Not yet.
You are not yet. So what is lumpy jaw is, see, like when you have an actinomycosis infection, there will be a hard woody-like structure. So this woody structure will be having a lot of sinus tract. And you know what do you mean by a fistula?
Yes.
Yeah. So they this sinus tract will have a inside tract and an outside tract. So this tract once the first and a tract is formed around a woody texture, that type of flat type of jaw is called a lump. So it's called lumpy jaw. Got it? Yeah. So you remember that. So lumpy jaw is seen in actinomycosis infection. Then the other forms of clinical manifestations are thoracic actinomycosis. It may infect the abdominal organs, abdominal actinomycosis. Then pelvic actinomycosis. Then pelvic actinomycosis occurs in intrauterine contraceptive devices insertion. Again, why it occurs in ICD insertion? Because on ICD insertion, you are again traumatizing the cervic wall, and it will cause again the inoculation of the actinomycosis into the uterus in the cervic wall, and it will cause actinomycosis. Then brain abscess. Brain abscess because there is transfer through the blood into the brain, and it causes brain abscess. And bone destruction, soft tissue destruction, that is directly from the jaw into the from the dental on doing a dental extraction of the soft tissue into the jaw, and it will cause bone destruction and soft tissue infection. Next is lab diagnosis. Lab diagnosis is done by microscopic identification of the sulfur granules. With a histopathological staining. Staining is done with hematoxylin eosin stain or a special stain called Gomery stain. The special stain I'll come in the general microbiology section. I'll be telling you about different special stains. So in that time I'll tell you about the Gomery stain. The next is granules is composed of eosinophilic clumps surrounding basophilic filaments and inflammatory cells. So there will be a central clump formation, and there will be basophilic filaments and inflammatory cells around the clumps, eosinophilic clump, and thus you will find like a sunray appearance. Culture, we grow this actinomyces on thioglycolate broth, and in thioglycolate broth you will find fluffy balls at the bottom of the tube, and it is done for actinomyces israeli. In brain heart infusion agar also is the second culture, and in that you will find a small spider-like colony, spider-like colony is in culture media. That is thioglycolate broth, you will find fluffy balls at the bottom of the tube, whereas brain heart infusion agar you will find small spidery colony. What are treatment? Treatment of this disease is we give penicillin, we give macrolides. Penicillin is a drug of choice. The macrolides and doxycycline are the other antibiotics. Other main empirical, the proper therapy is if this medical therapy does not work out, then we go to surgical removal, which may be required for extensive lesions. This actinomycosis are the like associated fungi, like small fungi, miscellaneous fungi. They might ask you like a 3-mark question, 2-mark question, not more than that. The next is nocardiosis. Nocardiosis is a gram-positive bacteria, and branching filament bacilli are seen. It's aerobic. It's acid by the bacilli, that is with acid fast with 1% H2SO4. You remember Mycobacterium leprae? What was the percentage of H2SO4?
20.
Was it 20?
Sorry.
5%.
5. Yes, exactly.
Yeah, 5.
5. That's right.
Yeah, 4 to 5%. Only the next.
I think pathology I was learning. It was 5. Yeah.
Yeah, pathology you were learning and you got confused there. I think 20% was, I think it's for Mycobacterium tuberculosis.
Maybe that.
Yeah, Mycobacterium tuberculosis 20%. Mycobacterium leprae is 5%.
Yeah, I think it is that.
Yeah. Only if I didn't take you class about Mycobacterium tuberculosis. It's yet to come. I will come in that.
We had practical last week. So.
Okay, yeah. So the next is only a few associated human infections are seen with nocardiosis. N. asteroidus and N. brasiliensis are the common pathogens. Pathogenesis is a heme-like actinomycosis. Soil is a natural habitat. Infection is occurred from soil by inhalation of fragmented bacterial filaments. Transcutaneous inoculation is seen. Person-to-person spread is not known in nocardiosis. Manifestation here are pulmonary nocardiosis, which is in pulmonary nocardiosis, most common manifestation is pneumonia, whereas extrapulmonary nocardiosis, it occurs via the blood. Brain abscess is the most common form in extrapulmonary nocardiosis. Lab diagnosis, direct microscopy. In my direct microscopy, we do with gram staining. Modified acid fast staining is done, and H&E staining of granules is done. Culture selective medium. The selective medium is buffered yeast extract containing polymyxin and vancomycin. Subaroid dextrose agar with chloramphenicol. Just need to know all these things. I don't think anybody will ask about lab diagnosis or nocardiosis. Yes, they might ask you what is nocardiosis, what are the lesions seen, what are the extrapulmonary manifestations. Sometimes they might ask you lab diagnosis. In my MBBS life, nobody asked about nocardiosis. I don't remember anybody asking about nocardiosis. The treatment is resistant to penicillin. That's why we give clotrimazole. Clotrimazole is also called as cymethoxylin sulfamethoxazole. That's CMX SMZ. That's a drug of choice for nocardiosis. So now we come to non-viral treponematosis. That is caused by three close relatives of Treponema pallidum. That is Treponema pertinue, which is causes yaws disease. Then Treponema endemicium, which causes endemic syphilis, and Treponema calateum, which causes pinta. In this, only thing we have to know is yaws disease. Yaws disease is also known as frambosia or boba. It is caused by Treponema pertinii. Epidemiology is this disease is mainly found in Africa, Southeast Asia, and Central America. In India, there were few cases in Orissa, in Chhattisgarh, Assam, Andhra Pradesh, and Madhya Pradesh. The transmission is by direct skin-to-skin contact, abraded or lacerated skin. Incubation period of the disease is 3 to 4 weeks. Majority of cases are children. Primary lesion, that is mother yaw. Primary lesion is called as mother yaw. Extragenital papule on extremities that enlarges in moist, warm weather to become papillomatous or raspberry-like. There will be regional lymphadenopathy. Secondary eruptions are more generalized. So first one will be, it's like there's a small primary lesion, that's extragenital papule on extremities that enlarges in moist, warm weather to become papillomatous or raspberry-like. And there will be regional lymphadenopathy, whereas secondary eruptions are more generalized, as there will be skin lesions, which is macular, papular, or papillomatous. Painful lesions on the feet results in crab-like gait. That's why it's called crab yaw. Now we come to treatment. Treatment is with azithromycin, which is a single oral dose is given. Single dose of 500 mg of azithromycin is given before yaws treatment. Now next is erysipeloid. Actually, I saw in a question, in the book question, there was a question for erysipeloid. That's why I just wrote a small. It's actually a very small topic. Positive agent is erysipelosis retiopathiae. Gram-positive bacillus causes erysipeloid. Is characterized by violaceous swelling with severe pain. Violaceous because the swelling is actually violet in color. That's why it's called violaceous swelling, and there is severe tenderness. Most common site is this swelling is seen in fingers. That's why the fingers will be like steel fingers or whale. That's why the fingers are called at that time as steel fingers or whale fingers. Transmission is found in people handling animals and fishermen. There's direct inoculation of the bacteria from the animal or the animal product. Treatment is with penicillin G. So I'm done with the skin bacteria. Now we'll come to the viral part of the skin infection. So now in this actually there are a lot of topics there. I think so 7 to 8 viruses. So in this actually there are 3 to 4 viruses which are important, and the other one are small topics. So it will be I might rush through it. If you don't, if you find it difficult, just interrupt me in middle.
Okay.
The bigger viruses I will explain to you data. Smaller viruses I might run through. So the herpes virus. Herpes virus is actually from the Herpes viridae family, and these common viruses you all know. It is like chickenpox virus, varicella zoster virus, shingles, then hand, foot, and mouth disease, then measles virus, rubella virus, then molluscum contagiosum, pox virus, smallpox. So easy. All viruses we know the general property, so you won't find it difficult to understand. Herpes virus is Herpes viridae family. It's a large virus. It's about 150 to 200 nanometer in size. It's spherical in shape. It has got a icosahedral capsid. Enveloped DNA virus. See, herpes. These most of the viruses which is infecting the skin are most of them are DNA virus. So it's a enveloped DNA virus, double-strand DNA virus. Segment. There is an area between the capsid and envelope, and an amorphous asymmetric structure present. I'll show you. Come to this is the virus. It's spherical in shape, icosahedral capsid. Between capsid and the capsule, there is an amorphous layer. There is an amorphous layer. This layer is called tegument. So now I'll come into different types of herpes virus. Let's classify into alpha herpes virus, beta herpes virus, and gamma herpes virus. Its classification is based on the duration of replication and cytopathology. The alpha herpes virus has a short time of replication, that's 12 to 18 hours, and it is cytolytic. whereas beta has a long time of replication that is greater than 24 hours, and it is cytomegalic, whereas long greater than 24 hours, it may be lymphoproliferative also, whereas gamma has a variable lymphoproliferative as a time of replication. Whereas alpha is the site of latency is mainly neuron, whereas beta, the site of latency is mainly in the glands, it may be the kidneys or lymphoid tissues. Whereas gamma, its site of latency means lymphoid tissue. It's only in lymphoid tissue. Latency means the where the virus will stay dormant for a long period of time, like carrier state. It will be alpha virus group of herpes virus is mainly in the neuron. Beta groups mainly gland, kidneys, and the lymphoid tissue, and the gamma mainly latency in the lymphoid tissue. There are different type of other names, genus you need to study. The names, different type of names of the herpes virus, herpes simplex virus 1, 2, then 3, 4, 5, 6, 7, and 8. In this, the herpes virus 1 is called herpes simplex virus 1, herpes simplex virus 2 is called herpes simplex virus 2, varicella zoster virus is herpes simplex virus 3, 4 is the Epstein-Barr virus, which is a gamma virus, 5 is cytomegalovirus, 6 is human herpes virus 6, but human herpes virus 6 is also called as human B cell lymphotrophic virus. It's not there in your textbook, it is I got from the outside, written from the outside. Then, did you get the today's slide?
No, not yet.
We didn't get. Last week's PDF you got?
Yeah, that I got.
Last class, not last week, last class.
Yeah, yes, that I got.
Yeah, you'll get the PDF, don't worry. So, herpes virus 7 is also called RK virus. Then, herpes virus 8 is Kaposi sarcoma associated herpes virus. So, Kaposi sarcoma is found mainly in
I don't know, sir.
immunodeficient state.
Pardon?
So, immunodeficient state, that is HIV people and people who are like having malignancy for a very long time. So, immunodeficient state. Kaposi sarcoma is mostly found in them. Okay. Now we'll come to herpes simplex virus infection proper. The herpes simplex virus infection is mainly by the alpha subfamily of the herpes viridae. Herpes simplex virus infects exclusively man. Remember that. Herpes simplex virus infects exclusively is man. Then it replicates fast. It replicates within 12 to 18 hours of the cycle, and it spreads fast and are cytolytic. Cytolytic means it destroys the cell. Spectrum of disease involving includes skin, mucus, and various organs. This alpha virus undergoes latency in nerve cells. It reactivated later, causing retinal lesions. That is, this is actually it undergo dormant stage in the nerve cells, at the mainly ganglions or tip of the nerve cells. And when sometimes there might be a triggering factor like a fever or something, which may again causes the reactivation of this virus, and retinal lesions will be seen in herpes simplex virus infection. There are two types of herpes simplex virus, alpha virus, herpes simplex virus 1 and herpes simplex virus 2. Herpes simplex virus 1, the difference between the two, herpes simplex virus 1 and herpes simplex virus 2 is seen here. The common modes of transmission is direct contact with the mucosa or the abraded skin, that is in herpes simplex virus 1. Whereas in simplex virus 2, it is sexual mode or there may be vertical mode. You know what do you mean by vertical?
No.
No, okay, fine. Okay, vertical means what? Like it's from the mother to the child. So
yes.
Vertical transmission, like from the mother to child, that is called vertical mode. So if you don't understand, right, some of the words which I am telling, just interrupt in middle and ask, okay? Because I don't know what all words, like you're in the second year, right? So I might go clinical. These clinical features are there, right? It's actually we study in final year, because those are the words which you study in a clinical posting, you read Hutchinson. And you should finish some of the posting like OBG and everything. I don't know, once you get in second year onwards, you're studying clinicals. It is really tough for you guys to study clinicals and microbiology, but it's easy. Once you understand the clinical words, then you'll find it easy during your final years to correlate in your posting. But it'll be tough if you don't understand the word. So the best thing is you keep a dictionary next to you. Like if you don't understand the medical terms, right? Just refer the Dorlands. You use this dictionary, Dorlands. There's one more dictionary, right?
Yeah.
Was it Dorlands and one more dictionary? The green color dictionary is there. I forgot. We used to use that. But I used to prefer Dorlands because it was much simple and easy to refer. Okay. So now next is in herpes simplex virus 1, latency is mainly in the trigeminal nerve. Trigeminal ganglia. Whereas herpes simplex virus 2, the latency you find in the sacral ganglia. The age affected by herpes simplex virus 1 is young children, whereas herpes simplex virus 2, it affects young adults. In herpes simplex virus 1, the common manifestation, there will be orofacial lesions. There will be orofacial lesion, whereas herpes simplex virus 2, mainly they'll have genital lesions. And there will be other manifestations like encephalitis and meningitis in herpes simplex virus 1. See, just imagine herpes simplex virus 1 affects above the face area. So it causes orofacial mucosal lesions. Complications like encephalitis and meningitis will be seen. Ocular lesions will be seen. Skin lesions are above the waist. Whereas in herpes simplex virus 2, it affects the genital lesions. Skin lesions are below the waist. There will be neonatal herpes. Why there will be neonatal herpes? Because this is spreads to the genital tract, and if the child is when the labor is done in normal labor, the child will get the disease from the mother. So it's called neonatal herpes. The next is neurovirulence is herpes simplex virus. The neurovirulence is less, whereas herpes simplex virus 2, the neurovirulence is more. Drug resistance is more with herpes simplex virus 2. Then last two antigenic homology, all you don't need to know about it. Whereas one more difference which is not there in the textbook is herpes simplex. The herpes simplex virus is grown in chick embryo culture. So herpes simplex virus, when herpes simplex virus 1 is grown on chick embryo culture, you find smaller pokes. Pokes means actually these these herpes simplex viruses are actually is grown on chick embryo culture by stab. So when these pokes grow, there will be smaller pokes, like smaller in size, small region. Whereas in herpes simplex virus 2, when the culture in chick embryo culture, there will be larger, smaller. There will be larger this eruption, poke region. So herpes simplex virus 1 will have smaller poke, whereas the herpes simplex virus 2 will have larger poke, and these pokes are similar to variola virus. When the variola virus is grown on the chick embryo, these pokes will the pokes of the variola virus is similar to large pokes. Herpes simplex virus 2. So these are the differences between herpes simplex virus 1 and herpes simplex virus 2. So you got it right? Yeah. Do you have any doubt?
No. No, sir.
No. Yeah. It's simple actually. So next is pathogenesis. This one actually the infection enters through the upbraided skin. It enters the cutaneous nerve fiber and is transported to the ganglia. It is transported by the retrograde axonal flow to the dorsal root ganglia. Virus replication. The site of virus replication is at the site of the infection, and then local nerve endings and at the root ganglia. That is where the the virus enters. There is the virus will start replicating. As in the cutaneous, skin, abraded skin, at that area itself, the virus start replicating. And the replication is also found in the local nerve endings and at the root ganglia also. It causes cytolytic infection. That is, it causes the necrosis of the infected tissue. That's why it's called cytolytic. That is, it destroys the tissue. So it's called cytolytic infection. Then latent infection. Latency in neurons. Herpes simplex virus 1, latency is in trigeminal ganglia, whereas herpes simplex virus 2 in sacral ganglia. It doesn't replicate in latent stage and also cannot be isolated. So remember, the replication in nerves is found only in the infective period. Whereas in latency, you won't find any replication in the nerves, and you can't isolate the virus also. Whereas I'll come to recurrent infection. Reactivation of the latent virus occurs following various provocative stimulus like fever, axonal injury, etc. It's less extensive and less severe. Usually it is asymptomatic. Virus continue to shed. So in this secretion, during recurrent infection, the virus will get again activated, but the extensivity of the symptoms is less extensive and less severe. Sometimes it will be asymptomatic. Virus continue to shed during the recurrent infection period. What are the clinical manifestations? Cell-mediated immunity is important to prevent from herpes simplex virus infection. So it's a cell-mediated immunity which protects us from herpes. Not all people infected with herpes simplex virus is not infected. So he is having the disease. So what's the clinical manifestation? It's only one who doesn't have a proper cell-mediated immunity. So once the cell-mediated immunity is suppressed, you get the herpes simplex virus infection. So virus isolated from the nearly all mucocutaneous sites and viscera. Oral infections more common with herpes simplex virus 1. I already told that. Herpes simplex virus 2 causes genital infection and uterine infection. Incubation period is about 1 to 26 days. Whereas oral facial mucosal lesion, as a cause of herpes simplex virus 1, is the most common manifestation of herpes simplex virus. Most commonly affects the buccal mucosa. Most frequent primary lesion is gingivostomatitis and pharyngitis. Most frequent recurrent lesion is herpes labialis. Labialis means, you know what do labialis means?
Yeah. Lip. Something
Yeah,
on
lip.
the lip.
Exactly, exactly. It's on the lip region. That's why it's called herpes labialis. Painful vesicle near lips are seen. Other lesions are ulcerative stomatitis. The patient will have tonsillitis and vesicular lesions in the eyelid. Many cases asymptomatic but can predispose to secondary bacterial infection. So that's what I told. When the sensitivity immunity is good, it will be asymptomatic. Just will have herpes labialis and just go off. But if there is the suppression of the immunity, there might be other complications and it may predispose to this herpes labialis. Actually, this herpes labialis or herpes infection might get crusted, and this crusting there will be secondary bacterial infection and other complications. So this is how the herpes labialis infection looks like. Vesicular lesions on the lips, that's herpes labialis. On the eye also, you might periocular vesicular lesions on the eye. Then cutaneous lesions. Cutaneous lesions are the different types of cutaneous lesions are herpetic vitiligo, that is lesions on the fingers of the dentist and hospital personnel. Then febrile blisters or herpes febrilis. Fever causes and fever can cause provocative herpes simplex virus to cause recurrent blisters. Then herpes gladiatorum, that is mucocutaneous lesions present on the body of wrestler. That is when the one wrestler is fighting with the other wrestler, he takes the wrestler on the back and puts him on the ground. So if the other wrestler has a herpes infection, herpes blisters on his body, that herpes infection will come on the shoulder of the wrestler. That's why called herpes gladiatorum. Then eczema herpeticum, herpes simplex virus in patients with chronic eczema. Severe form as extensive local viral replication and spread is seen. So, if a patient has a chronic eczema and is super infected by a herpes simplex virus, and this eczema actually one complication that the person keeps on itching and there will be open wound. So the virus will easily enter into the eczematous lesion and it will cause more local viral replication and spread. Then erythema multiforme, herpes simplex virus most commonly associated with erythema multiforme. Then next about neonatal herpes. Newborn acquires infection from mother through natural vaginal labor. So imagine if a patient, female patient who is pregnant, has a herpes virus infection, and the herpes virus 2 infection and it causes genital herpes. But the patient is posted for LS, and will the baby have neonatal herpes or not?
Yeah. Sir, can you ask the question one more time?
A patient who is having neonatal herpes genital herpes is is pregnant and she is posted for LS, and the baby is delivered after LS. Will the child have neonatal herpes or not?
Yes.
Okay, actually, actually it is no, because why this neonatal herpes doesn't spread to the body fluid. Sorry, like through the placenta, doesn't spread to the placenta. It actually spreads through the body fluid. So if the baby has to get neonatal herpes, the baby should pass through the vaginal canal.
Oh, you were asking the other way, right? I thought it was.
No, I said the baby is having the mother is having LSCS, and the baby is born through LSCS. So will the baby
LSCS.
neonatal herpes? LSCS is actually cesarean section. Okay, sorry, you didn't get the word right. So it's LSCS cesarean section. It's a short form. It's actually lower abdominal cesarean section. Okay. So actually, if you do a cesarean section, the child won't get, because this infection is found, this virus is found only in body fluid, so mucocutaneous area. So if the once the baby passes through the cervix, then only the baby will get the infection. Otherwise, if you do cesarean section, the baby won't get the infection. Remember that. Oh, because they might ask you, like if you are applying for like multiple choice questions or anything, they might ask whether which are the infection which the baby gets through the placenta or which the baby won't get through the placenta. So in that, herpes simplex virus infection won't get to the placenta. It's just passing through the genital tract. That's why vertical spread, you might get confused with the vertical spread. Okay, now we'll come to neonatal herpes. The three categories are there. Lesions seen in neonatal herpes is lesions localized to the eyes, skin, and mouth. Encephalitis with or without localized skin involvement is seen. Disseminated diseases involving multiple organs, including the CNS is seen. Cause of mortality is mainly the disseminated disease with viral pneumonia, or there might be intravascular coagulopathy.